Good afternoon, everyone. I'm very happy to open the session, free paper session about central serous chorioretinopathy with my co-chair, Professor Bandello. And I would like to remind the speakers, please keep the time. It's 5 minutes and 1 minute discussion. And I would like to ask the first speaker, Ellen van Dijk. His topic is distinctive choroidal vascular hyperpermeability patterns in CSC correlate with OCT angiography parameters.
Thanks a lot for the introduction. I will indeed talk about the hyperpermeability on ICGA in central serous chorioretinopathy and how that is related to findings on OCTA. Like you all guys know, in central serous chorioretinopathy, there's a subretinal fluid accumulation, usually in the fovea. This can be best appreciated on the OCT scan, on which you can also find out some pachychoroid findings. But the combination of FA and ICGA is of the utmost importance in order to make the diagnosis. So usually there's a bit of leakage on the FA together with the indistinct abnormalities on ICGA with an indistinct border. So you really need the combination in order to establish the diagnosis. We found out that the choroidal venous hyperpermeability on ICGA is diagnostic for CSC. And there are 3 patterns that correlate with chronicity. So that's unifish, multifish, and dish. I'll quickly come back to that later. In the current study, we tried to find out how CVH patterns were correlating with findings on OCTA in our CSC patients. So coming back to the 3 categories we designed, it's unifish, so unifocal signs of indistinct hyperpermeability on ICGA. Then it's multifish, so multiple areas of this indistinct abnormalities on ICGA. And there's dish, the diffuse indistinct signs of hyperpermeability, like you see here. In our retrospective study, we had a look at a few patients from Amsterdam UMC and we retrospectively studied them. And based on the multimodal imaging results, we had a look if we could correlate the findings on ICGA to the OCTA findings. 2 graders independently assessed the CVH patterns based on mid to late phase ICGA. And we also had a look on the OCTA, so the Zeiss Plex Elite machine, on the superficial, deep, and total retinal layers. And we mainly had a look at the vessel length density and the vessel perfusion density. We included 172 eyes of 89 patients. And these patients mainly had multifish, so 52% had multifish, a quarter of them had unifish, and a quarter of them had dish. We had a look at the average length, vessel length density on the OCTA, and then found out when there's more signs of chronicity, the length of the vessels decreased, and that was both on the ultra-wide field and the 55-degree ICGA. We saw a similar pattern in the average vessel perfusion density, so the more chronicity we found on ICGA, the lower the vessel perfusion density was. So based on that, we conclude that the more chronic, so the more severe pattern on ICGA, there's a decrease in average foveal vessel length density in the superficial SWAP when we have a look on the 55-degree ICGA. We saw a similar pattern when we had a look on the ultra-wide field ICGA. And we also find out that the perfusion density in all 3 SLAPs decreased when we found a more chronic picture on the ICGA. Based on this study, we conclude that the advanced imaging techniques are really important for CSC evaluation, so including FA, ICGA, and OCTA, and that microvascular changes on ICGA are associated with CVH patterns on ICGA in central serous chorioretinopathy. The more severe the disease is, the foveal perfusion density decreases, and I would like to thank you all for your attention. Still 2 minutes left.
Are there any questions from the audience? I see many experts here in the room.
Do you analyze the chorioretinopathy with OCTA?
In this study, we didn't. So mainly we have a look at the OCT on the choriocapillaris in order to find, for example, an MNV. But for the current study, yeah, we didn't do that. But usually you have a look on the choriocapillaris slab in order to find out if there could be an MNV. But I would say, as I still got a minute or so I can talk a bit, but usually I would mainly have a look on OCT in order to find your suspicion for an MNV, but usually then the OCTA can be of added value. No, not in this study. No.
Any therapeutic implication for these kind of observations?
Yeah, that's always a good question, right? So people often say then, yeah, is it worth it to divide those patients based on ICGA? But I really think that the several studies we've published on this topic, the more extensive the abnormalities on OCGA are, the more severe the disease is. And I think this is supportive in that respect. Thank you.
Thank you.
Yep.
Thank you very much. Next speaker is Jennifer Chang-Wolf, and the title is Distinctive Choroidal Vascular Hyperpermeability Patterns in Central Serous Chorioretinopathy Correlate with Retinal Sensitivity. Where is it? Disappeared, sorry, I cannot finish. Sensitivity levels on microperimetry. Thank you very much, please.
Yes, thank you very much for that introduction, and thank you to the chairs, to the audience for coming to our presentation. It is my honor to discuss on behalf of my collaborators the choroidal vascular hyperpermeability patterns in CSC and their correlation with microperimetry. As Dr. Van Dijk just discussed, we found in our previous studies that choroidal vascular hyperpermeability, or CVH, on ICGA is diagnostic for CSC. There are three patterns in particular that correlate with chronicity. These are unifish, multifish, and dish, and they correspond with unifocal, multifocal, and diffuse indistinct signs of choroidal hyperpermeability, respectively. We also wanted to look at retinal function, which can be assessed via microperimetry with a scanning laser ophthalmoscope, or SLO, to track a retinal movement and correct for minor changes in fixation. Microperimetry was used as a clinical outcome in the PLACE and SPECTRA RCTs, for example, and was found to be very sensitive for retinal function assessment. So our question now is, how do CVH patterns correlate with microperimetry in CSC? We looked again at our CERTAIN cohort. It was a retrospective study on CSC patients who were referred to Amsterdam UMC for multimodal imaging. In our performed a linear regression between outcomes on ultra-wide field and 55-degree ICGA, in which two graders independently assessed the CVH patterns based on mid to late phase ICGA. And we also looked at MAIA, which is the macular integrity assessment of retinal microperimetry. That was further subdivided into macular sensitivity, in which a mean was taken of all 37 points on a circular grid, and foveal sensitivity, which was a mean of just the 13 innermost points. And so coming back to this graphical display of unifish, multifish, and dish, you can see on macular sensitivity broadly that there already seems to be a correlation between the chronicity and worsening function. And also, if you zoom in on foveal sensitivity, this was suggestive of a correlation. Overall, we looked at 154 eyes of 91 CSC patients with a mean age of 48, about 4.5 times as many male patients as female, which is expected for CSC, a medium symptom duration of 6 months, and slightly worse vision in the study eye that had subretinal fluid, or SRF, compared to the fellow eye that did not. And the subdivision of the CVH patterns was slightly over a quarter for unifish, slightly over a half for multifish, and slightly under a quarter for dish. Now, on macular sensitivity, we noticed that there seemed to be a distinct difference between unifish and dish for microperimetry. And if you looked at foveal sensitivity, although this analysis was slightly underpowered, there was a trend towards a difference between the unifish and dish groups. We wanted to increase the power of our findings by combining the unifish and multifish groups, since they had a similar distribution, we noticed, and overall they are focal compared to the diffuse findings in dish. And we found that indeed, if you take the fish group as one combined group, then you have a starker difference between fish compared to dish and on both ultra-wide field and 55-degree CVH grading, looking at macular sensitivity. For foveal sensitivity, this was slightly less powered to find a difference, but there does seem to be a slight distinction between the two. Overall, our study has shown that CVH patterns on ICGA are correlated with functional outcomes. Specifically, we find that DISH is associated with decreased macular sensitivity, about 2.5 decibels compared to unifish, and about 3 decibels combined to a combined fish group. And there's a trend towards foveal, decreased foveal sensitivity, although we were not able to display that as clearly as the difference on macular sensitivity. And I'm proud to announce that the study was recently accepted by Acta Ophthalmologica, and so you can be on the lookout for a publication in the coming weeks. I'd like to thank you for your attention, and I'm open for any questions.
Thank you. Any question from the audience? Please. The microphone is behind you.
Rolaba Abad, consultant medical retina and inherited eye disease, Riyadh, Saudi Arabia. Thank you so much for the presentation. It was quite informative. I have just a question about the timing of microperimetry in correlation with the activity of CSR itself and the amount of subretinal fluid.
Yes, so all of the patients that went through this protocol had microperimetry tested at the moment of consultation at the academic hospital. So these are all based on the initial presentation around the same time as ICGA and FA imaging was taken.
So I gather in some of them subretinal fluid was still there, and in others it might have been the first presentation while probably the patient was in remission, especially in the acute cases?
No, all of these are acute presentations of, they're presentations of CSC, and the microperimetry actually is similar to, in a way it's comparable to visual acuity in the sense that we are measuring retinal function, but then it's not like a OCTA where you might have some noise on the basis of the presence of SRF.
Did you make,
sorry, just what I meant was basically even if you do rapid, relative afferent pupillary defect, sometimes you can detect one simply because there is some amount of subretinal fluid. So the subretinal fluid per se can decrease the retinal sensitivity. This is in contrast when you have chronic presentation where you have atrophy of the photoreceptors and also the RPE might be impacted severely.
I appreciate the comment.
Okay.
Sorry.
I think we need to move, I'm sorry.
Apologies. Thank you for the question.
So then I would like to invite the next speaker, Parul Yadav. She will talk about evaluating the safety and efficacy of topical difluprednate in patients with CSC and comparison with oral eplerenone.
Hello everyone, I'm Dr. Parul, a third-year junior resident at AIIMS, New Delhi. And today I'll be talking about the safety and efficacy of topical hypertensive steroids like difluprednate in patients with chronic CSC. So the rationale for this study came from there is no universally accepted management of chronic cases of CSC as such. So we would like to evaluate this treatment as an option, as there have been a few studies which have suggested the role of intravitreal dexamethasone or topical prednisolone in chronic cases. So in our study, we recruited 53 adults, and we randomized them into 3 groups. In group A, we gave topical difluprednate 4 times a day for 3 months. The group B, we gave tablet eplerenone for 3 months, 50 mg OD. And in group C, we maintained only a strict blood pressure control. The blood pressure control was maintained in all the 3 groups. And we measured various parameters like the central macular thickness, subfoveal choroidal thickness, as well as the vascularity index, including the average thresholds at various intervals up to 3 months. So in our study, we found that group A, which is the difluprednate group, had 90% complete resolution as compared to only 23% resolution of the subretinal fluid in group C. Along with it, there was also a decreasing trend of central macular thickness, as well as subfoveal choroidal thickness, and a significant increase in the average threshold at the 3 millimeter circle at the microperimetry. So as we can see here, this is the OCT imaging of a patient in group A, which shows almost complete resolution of subretinal fluid at day 60. And similarly, we can see a net increase in the threshold of about 5.5 decibels. However, in group B, there was, which is the eplerenone group, there were 45% complete resolutions, and the only trend which was significant was a decrease in the CMT. And the mean time to a resolution of the SRF was about 57 days in group A and 65 in group B. Here's a patient with a partial resolution of fluid on eplerenone for 3 months. And similarly, the thresholds, however, show an increase, but the increase is very minimal of about 0.82 decibels. So this is a regression model in which we have highlighted that the decrease in the CMT and choroidal thickness has a positive correlation, that there's a positive correlation of the decrease along with the time. And in group B, the positive correlation can only be seen in the CMT. Along with it, we noticed several adverse events during our study, like IOP rise in difluprednate group and deranged potassium levels in the eplerenone group. However, they were managed on anti-glaucoma medications, and 1 patient from each group had to be dropped out. Along with it, we also analyzed certain OCT imaging characteristics, and the ones highlighted in red were an indicator with the poor prognosis or were non-responders in our study. So like the patients with intraretinal fluid, serous and heterogeneous PEDs, and double layer sign, they were poor responders. However, the one highlighted in green, which had larger vessels in the outer choroid and a diminution of choriocapillaris layer, these patients responded well to the given treatment. We also observed 3 distinct patterns in the fundus autofluorescence, in which the punctate hyperintensity pattern was associated with a good resolution of subretinal fluid, and a patchy hyperintensity, however, indicated a poorer prognosis. So as we know, when the choroidal flow increases due to steroids or a stress-induced dilation, it is usually returned back to its normal state by the autonomic regulation which exists in the choroid. So, but however, in CSC patients, we hypothesize that there is a defect in the sympathetic neuroregulatory system, so which prevents this, which prevents the returning of the vessels to its normal state. And the topical steroids likely bypass that mechanism, that failed autoregulation, and they act locally and directly at the vessels to cause vasoconstrictions, potentially by potentiating the effects of the catecholamine receptors. So that's all. Thank you for your attention.
Thank you for this talk. Are there any comments or questions? Yes.
Thanks a lot. Congratulations on this presentation. Aren't you just looking at the, let's say, spontaneous resolution rate of CSC, as the effect of eplerenone is already 45%? When you have a look at the larger RCTs, you see that placebo treatment is as good as eplerenone. So I'm a bit confused by the, let's say, the percentages you've showed.
And I wanted to make a comment actually going a little bit in the same direction. Probably I missed it and you told it. How did you actually diagnose, on what kind of basis you decided what type of CSC this patient has? Because as you have shown the OCTs images, there was like a widespread variety regarding chronicity or recurrent CSC.
We recruited patients with greater than 3 months of history of chronic CSC. And along with it, we recruited only those patients who had a subfoveal or a juxtafoveal leak. Those were not amenable to a focal laser treatment.
And what do you think about the eplerenone success rate versus your success rate after the prednisolone drops?
The difluprednate group showed a better resolution as compared to both the eplerenone and the control group, in which we essentially did not give any treatment.
In 18 patients, right? 1/8. Thank you.
Yeah, in the difluprednate group.
Another comment?
Yeah, what happens after 3 months of treatment with topical steroids? You have to keep them on treatment, or?
We have observed, like we took 20 patients, so out of them 18 resolved, and we kept them on regular follow-ups even after stopping the drug. So we observed a recurrence in the CSC in about 5 to 6 patients out of them. But again, we started them similarly on the same regimen again, and it resolved again.
Okay, so you don't taper them, you just stop them after 3 months and then wait until they
No.
recur?
We first give them 4 times a day, and once the fluid is completely resolved, we taper them to twice a day for 2 weeks, and then we stop the drug.
Thank you.
Thank you. Thank you so much. We need to move on. The next speaker is Peter Kirali, and the title is Morphological and Functional Outcomes in Long-Term Natural Course of Peripapillary Pachychoroid Syndrome. Please.
Good afternoon. It's a pleasure to give a talk about morphological and functional outcomes in the long-term natural course of peripapillary pachychoroid syndrome, or PPS. As you know, PPS is within the pachychoroid disease spectrum, and it is characterized by thick choroid around the optic disc, and these intraretinal cysts that are actually the hallmark of PPS, because this is what distinguishes PPS from other pachychoroid diseases. These cysts originate from hyperpermeable intervortex venous anastomosis around the optic disc, as you can see on one of our patients on the ICG. Now, PDS conditions have different natural course treatment and outcomes. We know polyps are very different to CSR patients. So I wanted to determine PPS characteristics at baseline and long-term natural course to see if any treatment is needed for these patients. So we did a retrospective study from 2015 to 2024 at the Oxford Eye Hospital, and we included 14 patients and 24 eyes. So 71% patients had bilateral PPS. At baseline, we examined the patient, we did OCT, autofluorescence, fluorescein angiography, and fluorescein and ICGA in the majority of patients. We followed the patients up for 6 months to 3.5 years without any intervention. The average age at presentation was 74 years, which means that these patients are a bit older than what we usually see in pachychoroid patients, such as in CSR patients. Male to female ratio was 10:4. That's similar to what we can see in CSR patients. And 4 out of 14 patients used steroids at baseline, which means that steroids could be a risk factor for PPS as well. However, only 3 out of 14 patients were symptomatic at baseline, and the majority of patients were referred to us because the community optometrists did OCT scans and seen intraretinal cysts. Very interestingly, and I'll come back to that in a minute, all patients at baseline had peripapillary atrophy, so 24 out of 24 eyes. Also, 5 out of 24 eyes had overlapping CSR PPS phenotype. What does that mean? That there was obviously there was thick choroid around the disc, some subretinal fluid, and some intraretinal fluid as well. So if we look, these are 4 patients, but all of our patients had peripapillary atrophy at baseline, and this is a strong clue where the fluid originates from. If you can see on the top ICGA and fluorescein angiography, there is no other leakage, but only a very discrete leakage coming from the at the area of peripapillary atrophy. And when we did OCT scans through that, you can very nicely see that these cysts start to originate from the area of peripapillary atrophy and then go distal to the optic disc. And because of that, we believe that peripapillary atrophy might be an anatomical predisposition for PPS to develop. And what happens is there is no RP barrier, which allows gentle seeping and oozing of fluid from the hyperpermeable choroid into the retina. This is one of our patients' longitudinal scans, and the patient had, at A and B, you can see the patient had only intraretinal cysts. So we would say peripapillary pachychoroid syndrome. But then at C, you can see that he developed also small PD, and through there, the patient developed subretinal fluid. So the intraretinal component comes from peripapillary atrophy, and subretinal component comes from the PD or RP bumps. And this is how an overlapping PPS-CSR phenotype can develop. What about visual acuity in our patients? Visual acuity at baseline was very good, 0.09 log-MAR, which means 6/7.5, and did not change during the follow-up, so without any intervention, as I said previously. We also noticed intraretinal fluid fluctuations in these patients. On the right side, you can see the thickness of the nasal macula. You can see it was thickest at baseline, then it decreased, and then it started to fluctuate a little bit. And in the middle, you can see a patient with a follow-up of 3.5 years. At baseline, a lot of fluid, then it resolved, then it came back again, and then it resolved. And another patient on the left side. So we see these intraretinal fluid fluctuation with this waxing and waning natural course, similar as you can see with CSR patients. But in CSR patients, subretinal fluid fluctuates, while in PPS patients, intraretinal fluid fluctuates. So to conclude, intraretinal cysts originate from peripapillary atrophy, which might be an anatomical predisposition for PPS to develop. Most patients are asymptomatic, and visual acuity isn't significantly affected. About 1/5 of patients present with PPS-CSR overlapping phenotype, and these intraretinal cysts follow a waxing and waning natural course, similarly as you can see with CSR patients, but their subretinal fluid fluctuates. Treatment usually is not necessary because visual acuity is not affected. However, it might be indicated with long-term foveal involvement or PPS-CSR phenotype. Now, we all know that PDT is the gold standard treatment for CSR, but it was also shown that in a smaller cohort on PPS patients that it is effective in PPS as well. Thank you.
Thank you. Any question? Camille.
Yes, thank you. Nice overview. It is an intriguing phenotype because you can also have patients without a thick choroid that have these peripapillary intraretinal changes, but I think you quite convincingly showed that there's a thickened choroid. What could help, because I'm not sure if you can already say that for this specific phenotype, PDT is already the gold standard, although there are some studies out there, I know. What would be useful, I think, is to do FFA ICGA, but then use a confocal ICGA system such as the Spectralis, because you can see these mid-phase hyperfluorescent changes better. And then if you see that it's very much into the spectrum of CSC, then I think it would be a better argument, for instance, to do PDT. But in my experience, it can be quite difficult to get this fluid away. And I have some horrible cases that progress whatever you give, from prednisone drops to PDT or whatever. So it's a tricky phenotype, I think. But I'm very interested about the atrophy, which is seen in all your patients. Very intriguing finding.
Thank you. There is another question or comment.
Thank you for your talk. I was wondering, is there also an inflammatory component? Because I have a few patients that really get out of control after surgery or laser treatment.
I mean, we don't know, but I think it's more hyperpermeability of the choroid. And the problem is that there is no RP, and because of that, there is gentle seeping of the fluid. So I don't think that there is inflammatory origin. I think it's similar, as you can see, with CSR. And obviously, also in acute CSR, you never see intraretinal cysts. But in chronic, you can also see where there is diffuse RP epitheliopathy. You can see sometimes intraretinal cysts because there's RP atrophy. And I believe that these intraretinal cysts develop because there's peripapillary atrophy, and like I said, fluid gently leaks around the optic disc.
Thank you so much. We have to move forward. Next speaker in this session is Vasileia, I hope I pronounce it correctly, Katsistergiou. Multimodal analysis of confluent hypoautofluorescence and its evolution in CSR.
Thank you for the introduction. It's not easy to pronounce Greek surnames, I agree. So I'm really happy to present to you a study on multimodal analysis of confluent hypoautofluorescence and its evolution in central serous chorioretinopathy. So we all know that blue autofluorescence is a way to detect RPE abnormalities in patients with central serous chorioretinopathy. And up to now, there are two patterns that have been described: granular hypoautofluorescence, as you can see upright, and confluent hypoautofluorescence. Both patterns are associated with poor visual outcomes. So the aim of our study was to determine the prevalence of confluent hypoautofluorescence in patients with CSC and to identify features associated with its development using multimodal imaging. So in a retrospective study at Lariboisière Hospital in Paris, we included patients with CSC examined between 2011 and 2024, and we excluded patients without imaging, patients with other retinal diseases, or a neovessel in the area where the hypotofluorescence developed. For the imaging analysis, we included eyes that developed confluent hypotofluorescence during follow-up, defined as an area larger than 1/4 of the optic disc. Focusing on the area where the hypotofluorescence developed, we analyzed fluorescein angiography and ICGA before the development of hypotofluorescence and OCT macular cubes before and after its development. So we analyzed 892 patients, and among them, 45 presented with a confluent hypotofluorescence, which actually corresponds to a prevalence of 5.04%. Among them, we further analyzed patients that did not present with confluent hypotofluorescence at baseline. And for the imaging analysis, we included 14 eyes. 75% of patients were male, and they were followed for around 7 years. So confluent hypotofluorescence in these patients appeared 4.5 years after the initial visit, and in 85%, the hypotofluorescence was located centrally. At baseline, in the area where the hypotofluorescence developed, 85% of patients already presented with granular hypotofluorescence, 64% presented with pachyvessels, 50% with mid-phase hyperfluorescent plaques, and only 10% with focal leakage. On OCT, we identified 3 different lesions: pigment epithelium detachment, dome-shaped or irregular, subretinal fluid, and less frequently, subretinal hyperreflective material. At the end of follow-up, pigment epithelium detachment and subretinal fluid decreased, while intraretinal cysts increased. And after the development of this hypotofluorescence, OCT characteristics were identical with the characteristics that we see in Serous in patients with AMD. So here I'm going to show you 2 different examples. This is an example of a female, 55 years old, that presented at baseline with a pigment epithelium detachment dome-shaped, subretinal fluid, and focal leakage point. And on the same area, 2 years later, she developed confluent hypotofluorescence. This is another example of a male, 51 years old, who developed confluent hypotofluorescence in a region with subretinal fluid, pachyvessels, and mid-phase hyperfluorescence. So our study shows that confluent hypotofluorescence is an uncommon finding in patients with central serous chorioretinopathy, with a prevalence of 5% in a really large cohort of almost 900 patients. 3 different lesions are associated with the development of confluent hypotofluorescence: pigment epithelium detachment, subretinal fluid, and less frequently subretinal hyperreflective material. Most confluent lesions developed in areas with granular hypotofluorescence and pachyvessels, and actually included the central fovea. Over time, pigment epithelium detachment and subretinal fluid decreased, while degenerative cysts increased, showing chronicity in these lesions. And this observation actually raises question about the role of RP cells in subretinal fluid dynamics. Thank you very much for your attention.
There is a comment.
Yeah, more question. Thanks a lot for your presentation. Did you perform FA and ICGA in all the patients? Because I'm not sure if the second patient you showed on the slide was definitely a CSC.
Yes, we performed the fluorescein angiography and the ICGA in all patients at baseline, actually.
And they all showed the typical, let's say, indistinct signs of hyperpermeability on the ICGA in the mid-phase?
Yeah, I believe so.
Please.
Great work, really interesting, thank you. I had a quick question, but maybe you said it. Did you find out, I guess these patients with chronic CSC had some type of PDT or laser treatment over the course of the follow-up. Did you find any correlation between PDT or laser therapy and the incidence of confluent hypotofluorescence?
Actually, given that this lesion is actually pretty rare and we only had 12 eyes out of 900, we had patients that were treated with in every possible way, but to be honest, we couldn't draw any statistically significant conclusion.
Okay, the next speaker will be Sarah Rayan. The title is Outer Retinal Microdefects in Central Serous Chorioretinopathy Long-Term Follow-Up. I invite the speakers to stay in 5 minutes for the presentation and 1 minute for discussion, otherwise we are already late.
Thank you for the introduction. So, as you know, outer retinal defects were first described in 1988, and there is no consensus on nomenclature. You can find different names in the literature: macular microhole, foveal spot, foveal cavitation, optical gap, and it also has various etiologies. I won't go into all the details, but as you know, some mechanical etiologies, vitreomacular traction, phototrauma, drug toxicity, Popper's toxicity, inflammatory, and also MacTel type 2 and central serous. So with our team, Professor Salomon Yves Cohen, we proposed this term in ophthalmology retina in 2021, outer foveal microdefects. And we reviewed all the 51 cases with these outer foveal microdefects in a tertiary retina practice in Paris. And we were surprised to find that approximately half of these cases with OAFMD had pachychoroid features. So we propose that pachychoroid may interfere with the healing process of the outer retina. Then we evaluated the long-term evolution of OFMD in CSC in our practice through conventional multimodal imaging and some cases with adaptive optics. It's a retrospective analysis, and we excluded carefully, of course, people with a blunt trauma, sun gazing, phototrauma, toxicity, and data collection included also treatment with laser. So we included 15 eyes of 10 patients. 50% male, 50% female. These were chronic cases. The mean age was 63 years. Mean duration of follow-up was over 5 years. And mean duration of subretinal fluid was 43 weeks. So here is a case of a 50-year-old male at baseline, and then after resolution of subretinal fluid, after only 4 months, you can already see outer retinal atrophy with diffuse easy attenuation after subretinal fluid resolution. And more focally, at the level of these hyperautofluorescent spots, you can see some of these optical gaps at the level of the outer retina after subretinal fluid resolution. Another case here, it's another configuration. After resolution of subretinal fluid, it's a chronic recurrent case. You can see the occurrence of outer foveal microdefects after resolution of subretinal fluid. So there is a kind of a diffuse outer retinal degree of atrophy and also some focal outer foveal microdefects. This is another configuration. In that case, the patient had CSE, but you can see the subretinal fluid was really nasally, and these outer defects seem to occur in an area where there was no previous fluid. That's a slightly different case that had been treated before for central serous and referred for second opinion. And I believe that case had PDT before, so that's a bias. But she had this outer foveal defect, which we thought was not fluid, and over the course of many years remained this optical gap in the fovea. So over 5-year evolution, there was no change in visual acuity, no significant change in height or width, even though there was a tendency to increase the width of this OFMD. The number of small defects increased over time, and the central foveal thickness decreased. The ELM was always preserved over time, and there was no... the elongated outer segments of the photoreceptors tend to regress over time, as I showed you on that case, and the posterior hypertransmission on OCT increased over time. So, to summarize, this is really like, I think we mixed in this preliminary study different types of things. There are some outer foveal defects that appear not in areas of previous subretinal fluid in the context of pachychoroid, some after resolution of small subretinal deposits or small serous avascular PEDs, and some after resolution of subretinal fluid. This is quickly one case that we documented with adaptive optics, and at the level of this outer defect, we could see the RPE mosaic because of the missing outer segments, which was quite unusual with this technique of imaging, and over time we could see this RPE mosaic quite well. We need to further analyze the RPE morphometry in these cases. So to summarize, This is a long-term 5-year follow-up of OFMD in chronic CSC, about 15 eyes. They correspond to irreversible loss of photoreceptor outer segments and should be distinguished from cerebrogenal fluid. The lesion size and visual acuity remained stable over time, and there was no case of resolution and no case of progression to complete RPE atrophy with confluent hypoautofluorescence in these cases. And there are different ones. They probably should not be mixed together. And thank you so much for your attention.
Thank you. We have time for one comment or one question only because we are a bit late. Please try to be fast.
Congratulations, Sarah. It's a beautiful talk. How do you explain the association of H sign with the interruption of the easy loss you showed in several pictures? Do you have an explanation?
Thank you, Elodie. Actually, no, I don't have a good pathogenesis explanation. I just described it as an OCT sign. I think we need to further analyze that. Thank you.
Thank you so much. We move forward to the next speaker, Sanghamitra Panda Jonas, who will talk about prevalence and association of CSC in the Beijing eye study.
Dear chairpersons, ladies and gentlemen, it's an honor and pleasure for me to present before you my study, Prevalence and Associations of Central Serous Chorioretinopathy in the Beijing Eye Study. These are my financial disclosures. The objective of the study was to assess the prevalence and associations of central serous chorioretinopathy in a general population in China, in the Beijing Eye Study. We used fundus photographs and optical coherence tomographic images, including a macular volume scan, to assess presence and location of CSC lesions. The CSC lesions were differentiated into an active form with fluid beneath the neurosensory retina and an inactive form with pachychoroid pigment epitheliopathy, PPE, with retinal pigment epithelium irregularities and dilated large choroidal vessels. Out of 6,551 eyes, CSC was detected in 1.1% or 70 eyes, 82% of which were males. Active CSC was found in 28 eyes, that's 40%, and inactive CSC in 28 eyes, also 40%, and eyes with both active and inactive CSC and PPE in 14 eyes, that's 20%. CSC location was only foveal in 18 eyes, that's 26%, only extrafoveal in 29 eyes, 41%, and mixed in 23 eyes, 33%. CSC occurred bilaterally in 25 patients, that's 56% of the patients. Both eyes of all CSC patients, also those with unilateral CSC, showed markedly dilated large choroidal vessels. The number of CSC lesions in each affected eye were ranged between 1 and 13. Higher CSC prevalence was associated with younger age, male sex, lower smoking prevalence, higher alcohol consumption, thicker subfoveal choroid, higher prevalence of intraretinal hyperreflective foci, and higher prevalence of macular hypopigmentation. In conclusion, both active and inactive CSC forms are relatively frequent in the general population. They often have a multifocal occurrence. They are often located extrafoveally. Frequent alcohol consumption was a positively associated factor, and smoking a negatively associated factor for CSC prevalence, which does not mean one should smoke. Thank you for your attention.
Maybe one short question, Elan van Dijk.
Thank you. Great work. I was wondering, can you then only diagnose CSC based on your OCT?
Yes.
Or is the differential diagnosis maybe a bit broader? So of course
it was a population-based study, so that's all. That's what we had.
Thank you very much. Congratulations. Next speaker is Legal Constance, quantitative autofluorescence in central serous chorioretinopathy. Please.
Dear chairs, dear colleagues, thank you for this kind introduction. And today I want to talk to you about quantitative autofluorescence in CSC patients. So as we've heard a lot today, CSC is the fourth most common retinopathy after AMD, diabetic retinopathy, and retinal vein occlusion. And patients usually present with acute or subacute central vision loss or distortion. And we've heard a lot of the hypotheses why this happens, about venous congestion, hyperpermeability of choroidal capillaries, but also the retinal pigment epithelium plays a role with its dysfunction. And the estimate bilateral disease is 50%. So in this study, we used QAF as an imaging modality because this one is well suited to detect alterations of the RPE. And the Delary grid is frequently used in order to look at QAF values in preset regions, as you can appreciate on the right side. And in this study, we basically had 3 questions in mind. So first of all, we wanted to compare QAF values in general of eyes with CSC. In unilateral disease, we looked at the fellow eyes and compared them to a healthy control group. And then we only looked at eyes with manifest CSC and looked at affected OCT regions in the quantitative autofluorescence and compared it to healthy macular regions. And as a third task, we compared the pathological regions with each other. So we were able to include 228 eyes of 145 patients. Mean age was around 51 years. And the mean duration since diagnosis was variable, but with a mean of 41 months. Group 1 were patients with a manifest CSC with 161 eyes. Then with patients with unilateral disease, we included 67 eyes that were asymptomatic fellow eyes. And then we had a healthy control group of 68 eyes with a BCVA 20/20. And here you can appreciate what we often see in clinic in unilateral disease. So one patient has a CSC and the other eye looks healthy. But if you take a look at the QAF, you might appreciate that it looks actually quite similar between these two. So this is what we did. We compared the mean QAF values in the inner 8 ring of the Delary grid and in the middle grid. And then we were able to see that not only the CSC eyes, but also the asymptomatic, presumably healthy fellow eyes had very similar mean QAF values and were significantly different to our healthy control groups. As a second step, we matched the OCT to the different areas of the Delary grid, and each grid we named as healthy or had subretinal fluid, had a pigment epithelium detachment, a pigment epitheliopathy. And here you can appreciate all of our findings and their mean QAF values, and also the number of eyes that presented with these changes. And we were able to show that the healthy regions actually had similar regions to the most common findings like subretinal fluid and pigment epitheliopathy. Only the areas with MNV, atrophy, and pigment epithelial detachment had higher values, though not significantly. And then, in conclusion, we can say that QAF values are higher in CSC patients than in healthy patients, but we found that they are not only higher in the CSC eyes, but in unilateral disease, also in the asymptomatic fellow eyes. So could that mean that CSC might rather always be a bilateral disease. And QAF values were not only elevated in the OCT areas with pathological findings, but also in apparently healthy OCT areas. And areas with MNV, atrophy, and pigment epithelial detachment showed higher QAF values. So QAF might serve as a screening tool in the future to identify itis at risk to develop CSC. So if we have a patient with a pachychoroid, it might be nice to tell him you've got a higher risk or not really, depending on the QAF values. And also we are still looking at or trying to collect longitudinal data in order to see, will the unilateral eyes in the long run also develop CSC, or will these QAF values change over time? But we don't have any results of that yet. Thank you for your attention, and I'm happy to answer any questions.
Thank you. Thank you, and congratulations. It's a very interesting topic. And is there any comment? Otherwise, we'll try to spare some minutes. Thank you. Thank you so much.
Thank you.
Then I'm happy to introduce the next speaker, Srishti Ramamurthy. Sorry for that. Talking about randomized controlled trial of efficacy, safety, and tolerability of intravitreal brolucizumab in CSC with persistent fluid without choroidal neovascular membrane.
A very good afternoon to one and all present here. I thank you for this opportunity. As mentioned, I'll be presenting the results of our RCT, which compared brolucizumab with placebo in eyes with chronic central serous chorioretinopathy with persistent fluid without a choroidal neovascular membrane. So there is a lacuna in literature when it comes to treatment of eyes with chronic CSCR, especially in the setting where there is no longer universal accessibility to photodynamic therapy, which is true in our subcontinent with inaccessibility to the vertebrophin dye. And with regards to pre-existing literature on anti-VEGF agents in CSCR, the results have been inconsistent with equivocal efficacy. So that brings us to our pilot study, which we did, where we looked at brolucizumab in these eyes. And as you can see, there was quite a dramatic response pre-injection and 1 month post-injection with almost near complete resolution of the intraretinal and subretinal fluid in these eyes. So with this background, we designed our RCT, where we compared brolucizumab with placebo in this subset of eyes of CSCR without CNVM. We included eyes which had persistent fluid on OCT for at least 3 months prior to recruitment in the study, and we conclusively ruled out CNVM in all these eyes with using OCT angiography in addition to FFA and ICG angiography. Eyes with previous anti-VEGF treatment history were also excluded. So this is just the workflow of our trial very quickly. So patients that were recruited were randomized in a 1:1 ratio, block randomization with stratification for central macular thickness as well as duration of disease. We did follow up at 1 month and 3 months. Now in the treatment arm, they received brolucizumab at baseline with repeat injections at 1 and 3 months in the presence of persistent fluid, while in the control arm, they received oral multivitamins daily during the period of the study. And at 3 months time point, patients in the control arm with persistent fluid were crossed over and advised intravitreal brolucizumab to look at the response there. So we are looking at eyes with quite chronic disease. You can see the median duration of disease in our study was 20 months. So visual acuity improvement may not be anticipated as they often have pre-existing photoreceptor loss. However, the purpose and primary goal of therapy here is to achieve fluid resolution to prevent further loss of vision. So OCT fluid resolution was our primary endpoint. This was the baseline characteristics, just to show that it was very equally matched in the treatment and control arms. For want of time, I'm not going into the details here. I'll go into our primary endpoint, which was fluid resolution on OCT. And as you can see in the treatment arm, I've shown an example here. At 1 month, 13 out of 22 eyes achieved complete resolution of fluid, both intraretinal and subretinal, 1 month post-injection brolucizumab, as opposed to 2 out of 16 eyes in our control arm. And at 3 months follow-up, 12 out of 20 eyes achieved complete resolution of, maintained complete resolution of fluid on OCT, compared to 3 out of 16 eyes in the control arm. So these are the other important endpoints looking at central macular thickness. You can see there was a significant trend towards reduction in the treatment arm of the central macular thickness, which was not seen in the control arm. And fortunately, even the subfoveal choroidal thickness did show a trend towards reduction. Baseline was around 470 microns, which reduced to 419 at 1 month, and then 403 at 3 months, the mean value in the treatment arm, while in the control arm, there was just a slight increase. The additional findings from our study, as anticipated, visual acuity did not show much improvement in these eyes in both groups. The control arm patients at 3 months, those with persistent fluid, we did a crossover. Now 11 eyes have undergone this crossover where they received the injection, and 9 of these 11 eyes achieved complete resolution with an injection brolucizumab. As you can see in the picture here, the patient OCT was largely similar at baseline 1 and 3 months, and after the injection, there was a complete resolution of the subretinal fluid. We have a follow-up of 6 months of the treatment arm for 15 eyes, and of these, 12 out of 15 eyes have complete resolution of fluid, and the mean number of injections during the 6-month period that they received was around 1.5. This is a major concern when it comes to brolucizumab, but what was heartening to see was that none of the eyes in our subset have developed any intraocular inflammation so far. So in the absence of availability of photodynamic therapy, brolucizumab seems to be a promising solution, helping to achieve rapid resolution of fluid in these eyes with chronic central serous chorioretinopathy. I thank you very much for your patient listening.
Thank you. So can you explain me the rationale for this kind of therapeutic approach?
Like I pointed out earlier, we no longer have access to photodynamic therapy. Eplerenone, I think we know from the VICI trial and other trials that it's no longer justified. It's not showing superiority over placebo. So in this setting where we don't have micropulse laser, we do try, but I think the PLACE trial has shown that it's inferior to PDT, and it's difficult. We don't have a specific endpoint. So with all these criteria in mind, we tried brolucizumab initially, and we saw a dramatic response. With that, we've done the randomized control trial.
Antonio.
Did you have any peripapillary phenotype in your group? And if so, how did they go?
I'm sorry?
Did you have any peripapillary phenotype?
I mean, there were patients which had peripapillary fluid, but I should have mentioned this. Inclusion criteria, patient did have to have subretinal fluid or intraretinal fluid at the macula. Those were the patients that we included, not just if they had the nasal distribution of fluid.
Okay, so you didn't divide in groups?
We didn't divide. It was predominantly patients with macular involvement that was included in the study.
I have 2 questions. How anti-VEGF?
No, only one, please.
Did you try other anti-VEGF?
Not in this study. In the past, we've tried, but the results were not this promising. You know, some reduction in fluid has been seen in the past, but not as effective as we are seeing with brolucizumab.
Thank you.
Okay, sorry, we need to move. Thank you very much. We have the last speaker now, who is Yu Jet Chong, and he'll present 2-year follow-up of outcomes and progression of eyes within the pachychoroid disease spectrum.
Thank you very much for the opportunity to speak. I currently work in Birmingham, but this work was completed when I was a research fellow at Singapore Eye Research Institute. So today I'm going to talk about the 2-year follow-up outcomes and progression of eyes within the pachychoroid disease spectrum, which is PDS. So as we know, pachychoroid disease spectrum is an umbrella term that includes a number of diseases, including what we have just heard, central serous chorioretinopathy, pachychoroid pigment epitheliopathy, pachychoroid neovasculopathy, and polypoidal choroidal vasculopathy, focal choroidal excavation, and peripapillary pachychoroid syndrome. So the underlying theory of the development of PDS is that it's based on the multi-hit hypothesis. A sequence of events is required to develop these diseases. So it starts off with anatomic predisposition, such as thick sclera, short axial length, and then there's possibly an inciting event such as steroids use, stress. Following that, there are compensatory mechanisms with dilated choroidal veins, intervortex anastomosis, and after that you get decompensation when the venous system is overloaded with venous stasis, and then you get hyperpermeability of the choroid, finally resulting in visual loss such as serous detachment, RPD damage, neovascularization, and outer retinal atrophy. So what we wanted to look at is that we want to report on 2-year longitudinal outcomes of eyes with uncomplicated pachychoroid and see what happens to them after 2 years. Our methods, this was a prospective, multi-center, longitudinal observational study of long-term outcomes of participants with the PDS phenotype. Inclusion criteria, age more than 45 years old, with subfoveal choroidal thickness of more than 300 micrometers. These patients were followed up at baseline, month 6, month 12, month 18, and then after that, month 24. So the results, we had a total of 239 eyes from 143 participants. So several of them had bilateral eyes enrolled into the study. So eventually, at 24 months follow-up, we had 207 eyes from 125 participants who completed the 2-year follow-up. The mean age of participants was 59 years old, and 74% of them were male. So these were our results. So UP, uncomplicated pachychoroid, 19% of them remain as at baseline. They had very good vision, as we would expect. So the Snellen equivalent was 6.6. For patients with PPE, the Snellen equivalent was 6.9, and for CSCR at baseline, the vision was 6.9. And for patients with PNV, which is only about 8.3% of them, the Snellen equivalent was 6.9 as well. So eyes with CSCR, as we would expect, and PNV had poorer baseline vision compared to eyes with uncomplicated pachychoroid and PPE. And overall, reassuringly, at 2 years, there was no change in visual acuity for this cohort of patients between baseline and year 2. I think what most of us would be interested in, but how many of them did have a change in a diagnosis, and then what happened to these group of patients? So 93% of eyes had no change in diagnosis at year 2. 7% of eyes, or 15 eyes, had a change in diagnosis, and the majority of these eyes, so 13 out of 15, had baseline diagnosis of PPE. And of those eyes, again, this is what we're most interested in because these are the patients that we need to treat. So 47%, or up to half of these eyes, which had a change in diagnosis, developed incident neovascularization, which required treatment. So I think that's all from me today. So overall, patients with uncomplicated pachychoroid, they tend to be relatively stable over 2 years, but some of them do have a change in diagnosis, and they can develop neovascularization. Happy to take questions.
Thank you. Any question? Yes, please.
Just a question. Thank you for this nice presentation. You looked at the follow-up of the subfoveal choroidal thickness and the prevalence of intravitreal anastomosis.
Did you say that, did we look at the presence of intervertex anastomosis?
Exactly, and the follow-up of the subfoveal choroidal thickness.
Yes, we did. So there was not very little change in subfoveal choroidal thickness from baseline to 2 years.
Also in eyes with progression.
In eyes with progression, yes, this is one of the subgroup analysis that we're going to look at, whether or not they had a change and increase in subfoveal choroidal thickness. But preliminary results, yes, there was an increase in subfoveal choroidal thickness for these eyes with progression.
So thank you very much. We have to close the session. Thank you for excellent talks and looking forward to next sessions. Thank you.